Welcome to Grand Rounds in Urology. Tonight, we're going to discuss bladder cancer drugs and some of the drugs that we're using in urology with all of the introductions of new drugs over the last year. It's really been something to look at and something to chase. So, we're going to talk to Dr. James Bienvenu, a urologist down in Knoxville, Tennessee at University Urology, and Leigh Sewell, CEO of Virginia Urology. I'm going to start it off and ask Dr. Bienvenu, with all of this new technology coming out and specifically with these new drugs, how do you decide, which ones to pursue? What do you want to introduce to your partners? And what kind of discussion goes on to think about even adding a new treatment line for your patients?
Yeah, thanks, Mark. I look at this a couple different ways. I first look at it as how I'm going to help my patient, right? I'm a physician first, and I want to make sure that, I give my patients what they need. And frankly, in bladder cancer, these patients don't want to lose their bladder, right? So, I mean, historically, if we look back 10 years, we didn't have anything but BCG and then pembrolizumab came around, and in the past 5 years, now we have, three more drugs in the high grade space, one in the low grade space. And ultimately, as a physician, we're trying to preserve their quality of life, preserve their bladder, and minimize toxicity, right? So, when I look at a drug, I say, okay, is it going to work? Is it going to work better than BCG? Is it going to prevent me from taking this patient's bladder out? And is it going to make them miserable in the process?
Okay.
From a practice owner standpoint, I want to make sure that it's not financially toxic to my practice, and I want to make sure
Yeah.
it's not financially toxic to the patients too.
Yeah. And then do you have discussions with your partners as to how this goes forward, or is it, kind of you bring it in and everybody, trusts you, or does your partners bring some of those in? How does that work?
I like to think everyone trusts me, but I know that they're all skeptical when it comes to, a $60,000 dose of medicine or higher. So we talk it through. We make sure that we're talking with other practices. Now, our practice is pretty aggressive with these drugs, and we understand there's a risk with that. So, we vet it to the best extent that we can, and we try to participate in trials so we know how the drug works, so we know what the pitfalls are, what we could get in trouble with, not necessarily financially, but getting those patients through it. And then we really understand where the drug fits in, so that when we're counseling our patients and we're documenting that we're not going to get dinged on the back end for giving someone something that wasn't indicated for them, and then say, oh well, we can't pay for that. And so we probably don't have a strong enough, I don't know if protocol's right, but a strong enough framework to really vet these drugs. And as we've gone through this process of introducing these new drugs to our practice, we've improved that framework, so we don't fall into those traps, the financial ones and the patient ones. But it's a lot to digest, especially when the things are changing so quickly.
Yeah. We've been swallowing quite a bit recently. So, and Leigh, on your side, when a physician comes to you with a proposed addition of a new drug, a new treatment pathway, what do you do as far as running protocols, talking to your RCM team? Kind of walk us through what that process looks like.
Yeah, I think first just understanding the drug, and is it an in-office injection or infusion? Is it once? Is it every 6 months? So kind of making sure we understand how it fits into the patient journey. But then really the next step is to talk to our revenue cycle team to understand if this is getting reimbursed. We always really start, well, the only sure payer we can be sure of is CMS. So typically, if it's a new drug, does it have a J code? Is it being reimbursed? Typically, if If it's not being reimbursed or it's iffy or they're waiting for the J code, we're not going to move forward at that time.
Okay.
So we wait until we know that it's something CMS is approved, and then we'll go ahead and, start with one dose, whatever the situation is, one patient, follow it through the system and ensure that we were reimbursed
Okay.
from the payer.
Very good. And you start with Medicare and Medicare Advantage plans and then roll from there, or?
So it's a good point because there's so many Medicare and Medicare Advantages and secondary plans associated with Medicare Advantage that I think about other drugs that came into this oncology space, not bladder, but prostate, other things that we've had to really focus in on the different types of Medicare, Medicare Advantage, if they have a secondary, if they don't. I think also there's the out of the gate price and the out of the gate reimbursement. And you really have to, on a monthly, quarterly, 6-month annual basis, you need to be doing look backs to ensure that you ordered it for X price and make sure that matches your contract and you receive what you ordered and it comes into your system. You charge what you need to be charging, and then of course you get paid. So that's sort of a 4-point check, and it evolves potentially over a 60 to 90-day period, depending on the payer. And unfortunately, it is somewhat of a not completely manual, but fairly manual process to, for lack of a better word, babysit these drugs, especially in their infancy.
Yeah. Yeah, very true. And so I mean, and I think a lot of folks steer away from the unlisted J code as they go through. I mean, we do have Medicare's quote unquote blessing as long as we're on the FDA approved list to step forward with an unlisted J code. And we do have the potential of the initial higher price with the WAC.
Right.
But it is, and we have seen some struggles with getting the payers to actually process them in a timely fashion across the board. And so, I mean, I can certainly understand waiting for the J code to come in. And then, of course, we have the step additionally between we get the J code, but we don't have the ASP.
Right.
And then you move to that next one. And so it is a varying degree of step through on all these things. Now, the other one I wanted to ask about is, I mean, there is a copay or a secondary that kicks in. Do either of your groups work at all with some of the grants and funding that's available, helping your patients through that? And Dr. Bienvenu, I'll start with you. I mean,
Yeah,
how does that process work?
we're certainly heavily involved in trying to get those grants for our patients. We have a very successful in-office dispensary for our prostate cancer oncolytics, and those grants tend to be more available for those. But we've worked with some of the industry partners for these high dollar bladder cancer drugs, and to their credit, these people that really can't afford them, we've gotten free drug across the board. And again, these are $60,000 acquisition price drugs, and I've got some patients that have gotten 4 or 5 doses on their assistance program and not paid a dollar. And so we try to be advocates for our patients, and to the copay point, we're very upfront with our patients. I tell my patients, listen, I'm not employed by a hospital system, and I want to get you what you need. And the hospital system won't get you what you need, and there's not a practice around here that can. But there's a patient portion that's owed, and so we have to we have to say, listen, this is what your copay is going to be. You're going to have to pay us before we give you the drug because we just can't pay for these drugs. And they're pretty understanding because they know that we're not the ones trying to, you know, rake them over the coals from a monetary standpoint. We're just trying to get them what they need and at what it costs. So
Yeah. And one more follow-up question for you on that is, have you found that as you've kind of stepped into the grant finding process, has it gotten easier over time, or are there, have you found that maybe one manufacturer is better than the other? Or, I mean, how is that? And do you have expertise, like one team member that's really focused on the grant process?
yeah, so I don't have personal expertise, but we certainly have someone with expertise on our team.
Yeah.
I feel like if it's gotten easier over the process, it's just because our team has gotten better at the process. There are certainly variations between what industry partner is going to help and to what degree they're going to help. I think they're incentivized to help because they want their drug to be successful. They also want to give the drug, and while they may be, covering the patient's copay, they're still making a lot of money off of these drugs. So it behooves them to make sure that the patients that can't get it at however they can.
Yeah. And Leigh, kind of same side for you. How do you navigate or inform your patients their copay, and what kind of assistance program do you guys have set up to track down all that stuff? Because we all know, I mean, with that copay, we're already on slim margins with sequestration and where all the commercial payers are. So what about your side?
We have a similar process in that through our IOD, we do collect the copay before we order the medication. But prior to that, after the physician, has ordered the medication for the patient, we have a dedicated navigator that solely focuses on the oral oncolytic, process from ordering to dealing with the patients, giving them their copay, etc. And then they're the ones that would be reaching out to the grants or partners for funding. The feedback I've gotten recently is that I think we get we get funding pretty regularly for the patients that need it. I've talked to them recently, and there really don't seem to be a large number. I'm sure there's a onesie twosie, but patients that aren't getting assistance if they need it.
Yeah. Yeah.
Of
Very
course, the
good.
drugs are getting more and more expensive. So we'll see, TBD what happens in the future. But it's been a strong program so far, but we do have a dedicated resource who's really following it through the entire process.
Very good. Well, I don't think we're done seeing new stuff come into the market. Maybe not at the same rate that we've been seeing it for the last couple of years. Is there anything else that you want to add to kind of your overall process and how you've dealt with these new drugs, and how they come in, and actually in the end the satisfaction with from your patients and from your practice overall? And we'll start with you, Leigh, for that one.
Yeah, I think from a business perspective, I said it a little bit earlier, but you have to audit and monitor these drugs even after you stand up the program, because it may be, monthly injection for 6 months, and the payer pays month one and month two. So you don't think anything more about it. And we've certainly had situations where then the payer denies it or they pay a lesser amount. So I think just really have some sort of reconciliation process within your finance or administration department where you're confirming that you were actually reimbursed, and then comparing that to the cost that you pay. And then, we've had situations, as I mentioned, where the reimbursement has deteriorated to the point where it's below cost. And then we potentially have to pause on new patient starts until we can understand what's going on and whether it's a specific payer issue. So then at times we'll work with the drug company to, they have revenue cycle support to help. But at the end of the day, if we're out of the gate truly losing money to provide that drug, that we can't do that. It's not sustainable. So I think just from the business side, one piece of advice is to have a process to continue to monitor those high dollar drugs, even after you get them off the ground.
Yeah. And Dr. Bienvenu, how about you?
Yeah, I mean, from the business side of standpoint, I would absolutely echo what you said. I mean, these things have to be monitored in perpetuity because, these insurers will stop paying for whatever reason, or they'll underpay you, and then you're 6 months down the road and you're way underwater, and if you haven't been watching it, you get in trouble. I would say that, as a practice that does a lot of this advanced bladder cancer stuff and works with a lot of industry partners, I've learned to push pretty hard on the industry partners and be frank with them. I want to use your drug. I think it's a good thing for my patients, but you have to help me out. You have to help me with these payers, and you're going to do the groundwork because I don't have the FTEs to do this all by myself. And if it's hard for me to do it and it's costing me more money than break even and I'm losing money on these things, I can't do that from a business standpoint. And if you want your drug to be successful, that you're going to have to support us. And most of those industry partners understand that, and they're out ahead of it. But sometimes they have to be reminded that these things are really super duper expensive, and if we lose a dose, it could completely upend the entire P&L column. Just one dose.
Yeah,
Absolutely agree.
it is, and I can tell you on the revenue cycle side, the other thing there's always more than one thing to watch. And yes, watching the acquisition cost is one thing. Watching your prior authorizations when those are required, and oddly enough, with some of your contracts, you need to watch what you're charging, and it may be a little bit different based on your contract. So, top to bottom, it's monitoring inflow, it's monitoring outflow, and it's really staying on top of it. So, very good. Well, I'd like to thank you both for spending the time talking with me, and appreciate the feedback and the candid discussion. And I'll open up any last things you want to add.
Yeah, thanks for having us. I think this is an important thing to talk about. We don't always talk about, as physicians, the business side of things and how expensive these drugs are. And it depends where you practice, right? Some people don't have to think about it, and other people do. And sometimes I'm envious of the people that don't. But getting people what they need sometimes is multifaceted, very layered thing they don't teach you in med school.
I agree. I think it's also great to connect with other groups when we're in the same boat, and we can create a larger mass to advocate for ourselves together.
Excellent. All right. Well, thank you very much again, and have a great evening.